Hello friends, today we will see this case in which an intra-lenticular pressure increased in the mature cataract. Now how to manage these situations with the perfect or good rhexis. These lenses have a high intra-lenticular pressure, and just like a pressurized balloon, when you enter into the capsule it ruptures, which gives rise to that classical Argentina flag sign. So you will see this, and there are various methods to manage the situation. One of them is double rhexis. So you go ahead and do a double rhexis. Here, while doing the rhexis, I realized that it is running to the periphery, so I stopped, replenished the anterior chamber with viscoelastic, and then proceeded to complete the rhexis, not a complete one, but rather a small rhexis, which would allow me a safe opening in the anterior capsule, which cannot extend into the periphery. Once done that, I went ahead and used a phaco probe and phaco tip to decompress the contents of the crystalline lens or the cataract, so that the intralenticular pressure is released. And it's very important not only to aspirate the contents, but also to move and rotate the nucleus so that the pockets inside also get released and the pressure is relieved completely. Then you make a nick in the capsule where you want the rhexis to be enlarged, and then continue the rhexis so that adequate size of rhexis is achieved. Once that has been done, it becomes a routine phaco, where you simply, the technique which I use is a horizontal direct chop. So you can see we have bisected the nucleus into two, and we can also appreciate the nucleus is not very bulky or large in size. Majority of that was liquefied cortex, which has been drained out first during the decompression, and secondly when the phaco process is going on. So we have divided the piece into four quadrants, and we are proceeding to emulsify them so that they are consumed and the bag is empty. I will just comment that this is a situation where the steep axis was lying onto the left hand side, so we have made a main incision for the phaco probe onto the left hand side, which is my non-dominant hand, proceeding for the aspiration of the remaining cortex. In such cases there is usually very flimsy and very small amount of cortex which is left behind, so we are removing it. Subincisional cortex can be removed or they can be left behind for aspiration once the IOL has been implanted, because there is no cortex on the posterior surface or the posterior capsule, so there is no hurry about it. Proceeding to implant the intraocular lens. This is a preloaded hydrophobic monofocal intraocular lens from Apasami Associates, and you will notice the trick here that the trailing haptic automatically goes into the bag if you simply dip down the tip of the cartridge while the trailing haptic is being ejected, and this saves you from dialing the IOL and saves you some time and one step. Now going ahead to remove the viscoelastic and also the subincisional cortex, which is now a safer option with the shield of the IOL present to protect the posterior capsule. I usually also go for opposite clear corneal incision if the corneal astigmatism is more than 1.5 diopters. So we have placed that opposite clear corneal to neutralize this astigmatism. Hydrating the wound is important to achieve good sealing of the anterior chamber. Inflating the anterior chamber, looking for the integrity. And this is the first post-op day picture. Look at the perfect centration of the IOL and very clear cornea. The vision is 6/9 and improving to 6/6. Thank you.